So welcome everyone on the occasion of World Aniridia Day. We are very happy to have with us two very renowned speakers and to be discussing this topic that goes unnoticed in most meetings. So to welcome, we have Professor Neil Lagali. He is a renowned researcher and internationally recognized expert in corneal diseases, regenerative medicine, and biomaterials. He is a faculty member at the Linköping University, Sweden, and he leads a research group which is focused on keratoconus, diabetes-related eye disease, ARMD, and yes, surface diseases like aniridia. He also utilizes a lot of advanced surgically induced transgenic disease models and in the treatment of diseases like keratoconus and neovascularization, and is also the associate editor of the Ocular Surface Journal. We are very happy to have you with us today, sir.
Thank you.
Next, we have with us another renowned person in this field, Professor Dominique Brémond-Gignac. Professor Dominique is a pediatric ophthalmologist, also deals with strabismus and ocular surface diseases. She is a professor of ophthalmology at the Paris University and heading the ophthalmology department at the Necker Enfants Maladies University Hospital, Paris. She specializes in the pediatric anterior segment disorders, oculoplasty surgery, and ocular surface diseases. In additional qualifies also in maxillofacial surgery. She is a prolific researcher with over 170 publications, book chapters. She's a recipient of the prestigious Al Bigland Medal Distinction from the University of Pittsburgh Medical Center. She serves as an executive member of the WSPOS, which is the World Society of Pediatric Ophthalmology and Strabismus, and leads major European research initiatives, Aniridia being one of them. She is actively involved in clinical research, teaching, and innovation. Welcome, Dr. Dominic.
So another of our very renowned speakers, Dr. Sangwan, he's the force behind our Center for Unknown and Rare Eye Diseases. He's a leading ophthalmic surgeon with over 25 years of experience and a pioneer of SLET, which is simple limbal epithelial transplantation. He has formerly been associated with LV Prasad Eye Institute, but currently serves as the Director of Innovations and Translational Research at Shroff Charity Eye Hospital. With multiple publications to his credit, he's the driving force behind a lot of our initiatives today.
Next is my co-moderator and friend, Dr. Abha Gaur. She's a consultant at the Cornea and Refractive Surgery Department and the Anterior Segment Department at the Shroff Charity Eye Hospital. She also did fellowship at Dr. Shroff Charity Hospital, and recently she is also the head of the department. She has extensive expertise in cataract surgery, corneal transplantation, especially pediatric corneal eye diseases and ocular surface disorders. She also is recognized for advanced clinical and surgical care, and she's a clinician scientist taking on many projects in basic research, especially related to ocular surface and corneal disorders. Thank you, Dr. Abha, for joining us today.
Yeah, move on, Shelja. Can you go to the next one?
Dr. Abha?
Yes, I can hear you, Shelja. Can you move to the next one?
Yeah.
Shelja, can you move to?
Yeah, I moved. I think a little bit of glitch in the connection.
Okay.
Yes.
So today we also have with us Shelja. Both of us have been trying to bring a change to the rare eye diseases. And I know again, another force behind especially management of pediatric ophthalmology. She's a senior surgeon in the Department of Pediatric Ophthalmology, Strabismus, and Neuro-Ophthal at Shroff Charity Eye Hospital, and also leads the ocular genetic services. She has multiple pediatric cataract surgeries and strabismus surgeries to her credit, and also oversees the pediatric services at our peripheral centers. Being a fellow from LV Prasad Eye Institute, she has also received her genetic training at NIH USA and has been the recipient of the ARVO Developing Country Eye Researcher Fellowship in 2020 with multiple scientific publications, especially pediatric ocular surface, that is MAC disorders, and aniridia is her area of interest. Happy to have you, Shelja.
Thank you, Abha. Next, I would request Dr. Sangwan to go ahead with his presentation.
All right, thank you very much for your kind introduction. Can you see my screen?
Yes, you'll have to go back.
Yeah, good evening and welcome you all on this Aniridia Day. I'm going to briefly talk about Center for Unknown and Rare Eye Disease, which we are building. And this is led by Shelja and Abha and our entire team. I'm going to talk about some of the rare disease, how we manage, and what we are trying to do through this center. This is a girl whom, a 9-year-old girl with SJS, who was treated, managed, and then within 2 years she develops this, dry ocular surface. And at that stage, there is no other technology which can help her, and MOOKP was not possible. So we did what we call a LVP K-Pro, which is done for her, and this she recovered 20/20 and 6 vision. So here see in SJS, like Aniridia, the surface is what is a problem. But unlike Aniridia, the internal systems are okay. Therefore, visual recovery is possible. Another boy from Lucknow, very young boy, look at his eyes, and then he gets affliction with the acute SJS and goes through multiple doctors, and no one was able to identify that what the problem was. Doctors assumed that is the surface is dry in both eyes, and then we saw and did a very simple intervention called mucous membrane grafting at the lid margin, and see how the child has grown and gone back to the school. Young boy presented to us in Sarof, acute SJS, and we did IV methylprednisolone, amniotic membrane in both eyes, and took a histology, conjunctival tissue for histological analysis. And at 6 months, you can see there is fairly a good amount of recovery. At 2 years, excellent outcome, hardly any residua. When we looked at his molecular signatures, we could find there is a good correlation at the clinical and molecular data at the time of presentation and at 2-year follow-up. Similarly, another boy, very young, very severe disease, unlike the previous, which were very mild disease, presented slightly late, 6 months later, and you could see that there is a surface which is very advanced affection. We did amniotic membrane, we did mucous membrane grafting, but the outcome in his case is not as satisfactory as it was in the first case. So our lab, led by Dr. Mehak Sapra, and along with 2 PhDs, we're trying to understand why these things happen and how do we correlate molecular signatures with the clinical phenotype. And this is the kind of questions that our lab is answering. At the same time, we are also collaborating with one of a startup from Bangalore. This is called Pandorum, and recently it was in Paris, where Innovate India representing one of their companies. We are developing exosomes which are derived from the mesenchymal cells, and these exosomes can be then used to treat the surface disorders, unlike using the mesenchymal cells. So this is a study which is being conducted at Kyoto, led by Professor Kinoshita and Kozi. And this poster was presented in RO this year and shows very nicely that there is a reduction in the all the parameters of damage. And this model, particularly chemical burn model, represent like an SJS-like disease in this mice model. So it is a very promising mode of treatment. And to further validate, I used in one of my patient in the acute SJS on compassion ground these human grade exosomes in mixed with the eye drops. And you can see there is a remarkable improvement within 2 to 3 weeks. Another patient of SJS, nothing was working for her, and we had fortunately exosomes, and they were used for 2 months, and she had a very good outcome. Her epithelial defect healed, and surface become much better. Now, when we see the child like this who had a chemical burn, and this boy has a chuna injury, when you look at the surface, the child was very unhappy, was not going to school. The father asked, can you do something about it? So we did SLET, simple limbal epithelial transplantation, and this is a 10-year follow-up of the same child. When you look at the microscopy, confocal microscopy, the cells is absolutely well organized, regenerated. The same is the corneal nerves. And now the SLET as a technique is being practiced all over the world with more than 95 peer-reviewed articles in index journals. This where another solution we are developing is liquid bioengineered cornea. This is a rabbit model of chemical injury. This project is being led by Dr. Abha Gaud at our center along with Pandora. So what we are trying to show is that you have a corneal opacity, then you remove it and put a liquid bioengineered cornea. It polymerizes in place and allows epithelium to grow. And I think this might be a good solution for aniridic keratopathy going forward, along with the exosomes. So these are further results of our flagship product called Curagenics, which is a mixture of hydrogel material along with the exosomes. And these are the readouts: histopathology, densitometry, pachymetry in a rabbit model. And look at the magnified picture, the human cornea, rabbit cornea, and diseased cornea, neurotrophic keratitis, and then 90 days treated with the Curagenics. Remarkable improvement. The aniridic keratopathy is very unlike the cases I showed, whether SJS, whether chemical burn. Here, the problem, the eye looks quiet, it is not inflamed, but the problem is the nerve conduction. And therefore, the tissue, the surface tissue, as well as intraocular tissue, does not develop very well. And whatever the procedure you do, they are not very successful. Like this is a family presented to us. The grandfather had a milder form of the disease. The father had slightly more severe, and the daughter has the most severe. You can see the surface in both the eyes very bad, and the left eye is NPL. So in these eyes, I have done in early 2000 CLAT, CLAW, CLAW, and cadaveric, and along with, and also KPROS. KPRO is slightly better, but the stem cell transplants are not very good. And these are obvious because the problem is not only on the surface or the epithelial tissue, it is much more deeper. And this is well outlined in the literature, the difficulties of success of the limbal stem cell transplant in these eyes, because there is a much widespread involvement, developmental issues, foveal hypoplasia, and these are some of the reported stem cell transplant outcomes, which are invariably very poor. In our Center for Unknown and Rare Eye Disease, we are trying to identify and prioritize certain diseases. We are 10 disease leaders, 10 diseases identified, a biobanking developed, and we are pursuing these diligently. And we are fortunate to receive a grant from Swiss agency Willich Stiftung to establish the center, and the 1 year is over. We are very optimistic that we will be able to establish a world-class center. Our aspiration is by 2035, we should be among the top 3 global eye research institutions, and this growth will be led by Cured. These are some of the data of the across our network and our consortium, where we have collated around 200 patients in our network, 330 patients in a multicentric study, biobanked 26 samples, and molecular testing done in 31 patients. This is the bigger, just beginning as about a year old or less than a year old biorepository, where we are building our database along with the biological samples from these patients. This is our team of clinicians spread in all subspecialties. These are the Cured team who are leading different initiatives and different disease leaders, along with our excellent team of genetic counselors. And this is our stem cell research group at SROF. Thank you very much for your kind attention, and thank you very much for the support.
Thank you so much, Dr. Sangwan, for that overview of what Cured is doing at SROF Charity Eye Hospital. Are there any questions for Dr. Sangwan from Dr. Neil or Dr. Dominic?
Selja,
Not
Dominic, we made a mistake about her publications. She has a very extensive, more than 270 peer-reviewed
Yeah.
publications.
Yeah,
Thank
yeah, could be more. It is what showed us on some of the websites. So sorry
Yeah.
about that.
Sorry, Dominic.
Could
Don't
be
worry, we are not
could
going
be.
to make a war of publication.
So
Just a point.
yeah, we just
It's
took it from the I think the
Yeah,
hospital website.
introduction.
Maybe
Yeah.
it's not updated. So I mean,
That's
sorry about
okay.
that.
Don't worry. So Virender, it's a very encouraging treatment you showed us, and it's very interesting, of course. We are really looking to probably share this kind of treatment, and it will be a good option because I see that you have some good results. We have different also possibilities, but it's not my topic today, so but we can discuss of that.
Yes,
Thank you
sure,
for your
we'll
presentation.
discuss.
Yes, thank you so much for this wonderful presentation and overview. I just wonder about you have a very rich corneal, or not corneal, sorry, tissue bank there of all these patient samples. What kind of samples do you have stored in this bank?
Selja, would you like to take that
Most,
question?
Yeah. So it's mostly the blood sample for genetic studies. And whichever patient undergoes, surgery, there we try to take conjunctival tissue samples or limbal biopsy or, sometimes even trabecular meshwork samples. The tissue samples are not so many, but blood samples, we have close to around 30, 40, and we have additionally sequenced some 30 patients. So that's
And
about the sample.
Neil, what I do, like for example, cataract surgery in SJS or MMG or KPRO. So at that time, I try to take samples like conjunctiva, in addition, lid margin, blood sample, then
Okay,
iris, aqueous humor. So we're trying to get as many biological sample when we're doing these surgeries in rare eye diseases.
that's great. Yeah. I mean, of course, there will be rarely, I mean, sometimes it will be done some kind of a transplantation where you save the button, the corneal button. In those cases.
Yeah.
So sometimes I take also, when I do a glaucoma surgery, I take a trabeculum also, and we try to get as many as samples as we can, but it's always difficult, of course.
See, our idea is that to build a very good biorepository of different tissues of blood sample and targeted tissue samples, so that one day we may be able to find some breakthrough treatment. We don't have to wait for samples. So that's the whole vision about developing this biorepository.
Yeah.
Good.
Okay. Thank you. So moving forward, I would like to now invite Dr. Neil Lagali for his presentation.
Thank you. Thank you so much. Thank you for that. I can share my screen. I hope.
Yes.
I hope that it's in the presentation.
Yes.
Yes. Okay, thank you so much for the very kind invitation from Professor Sangwan and Dr. Fuda and Dr. Abba and the Ross Charity Eye Hospital. Really pleased to be here to talk Aniridia Day about, my talk will be about Hope on the Horizon, emerging therapies for Aniridia-associated keratopathy. So as we know, the AAK is one of the most difficult, challenging conditions to treat, and there is a lack of effective treatments for the condition today. We know that AAK is a result of dysregulated limbal stem cell function. It's bilateral in patient, so we cannot rely on the patient's own tissue. It's characterized by chronic wound healing and inflammation in the eye, and progressive, of course, infiltration by both blood and lymphatic vessels. And this is, of course, leading to the loss of cornea. We use a lot of animal models to try to understand AAK because it gives us the possibility to examine the tissue and the protein and the gene level that we can't do in patients. So we're using a very human-like model of aniridia, mouse model, with a delayed onset phenotype of AAK, just like we see in patients. And so this is the small eye mouse model with the heterozygous mutation 6. And in this mouse model, we can see here that we have a spontaneous invasion of both blood and lymphatic vessels into the cornea. So this we published on this model. Also, the model was originally developed by Elizabeth Simpson's group in Canada, and we've been working extensively with this model to document the progressive changes. And you can see compared in the first row, compared to the wild type cornea, as the mouse gets older, the cornea stays nice and transparent. Whereas in the AAK model, we have different phenotypes. We have a early onset, and you can see in the middle row that the blood vessels are progressively growing into the cornea with the latent stem cell deficiency. And then we also have a later onset phenotype as well. And so this is not only evident in the slit lamp images. However, we also see that there's a dysgenesis of the anterior segment. We can see that there's a reduced anterior chamber depth. And the corneal epithelial thickness, the total corneal thickness and the epithelial thickness is reduced. We can see it here in these images. The epithelium is much thinner in the mutant mice, the PAX6 mutants, and the epithelial barrier is absent. So we can see that it fluorescein stains the entire cornea in the case of the PAX6 mutation. There's also no epithelial basement membrane present as well with the PAX6 mutants. So we use this, for example, to do a transcriptomic analysis of the cornea and see how this differs at the transcript level, at the whole genome level from the wild type. And we can see many different processes are dysregulated. For example, the differentiation, epithelial differentiation is dysregulated. We have a keratinization processes occurring, as well as many cellular processes of inflammation, cell adhesion is disrupted, cell motility, and then the MAP kinase pathway is very central as well. And so we use this model now to test new emerging therapies. And one of these, we just published this year, one of these potential therapies is duloxetine. So what is duloxetine? As you may know, it is a widely used drug. It's a serotonin norepinephrine reuptake inhibitor, and it's been used principally in treating a depressive disorder, anxiety disorder, but also diabetic neuropathy, fibromyalgia, and chronic pains, and so forth. It inhibits reuptake of serotonin, and for our purposes, this work was done by Daniel Aberdam, who was a dear colleague of ours who unfortunately passed away last year. He pioneered the work with duloxetine to try to repurpose the drug. What he did was he screened a drug library for drugs that could enhance the expression of PAX6 in cells, and these were in HEC293 cells, and one of the highest hits was duloxetine. So we continued this work with in vivo in mice, just giving the drug topically at 1 or 10 micromolars in the eye drop form for 7 days, and we could see that after 7 days, it does, at the protein level, it did increase the expression of PAX6 in the epithelium. And with this, we wanted to then, this was in wild type mice. With this, we wanted to see if this could actually work in the PAX6 mutant mice with the deficient PAX6 deficient levels. So we used the mouse model that I explained before. together with Dr. Brémond-Gignac's team in Paris, formulated duloxetine as an oily eye drop formulation and applied these to the mice for 90 days, giving the drops two times a day. With both early and late stage AAK. And you can see in the graph here the stages. So the early stage here, the lighter color, and the late stage, the darker color. However, post 90 days of treatment, we did not see any appreciable effect in the already established keratopathy. And we confirmed this at the tissue level, at the histology level, as well as PAC6 enhancement. There was no significant enhancement of PAC6 with this therapy we used 10 micromolar level. However, some of this work was presented at a ARVO conference as a poster, and a group we talked with there decided to take this further and actually use duloxetine in the first treating the first patients with AAK. And this was published late last year. They published a case report of duloxetine treatment, and here's some images from that paper. So it was an eye drop formulation. However, they used a concentration that was about 1,000 times higher than what we used. So this was at 6 millimolar, and patients received this eye drop, 3 eye drops per day for up to 1 year. And here you can see in the slit lamp images, there is a reduction of scarring or opacification in the cornea. We can also see on OCT that there was a reduced thickness of opaque tissue of the panis. And as well on the slit lamp imaging, it was with the fluorescein, it was the corneal epithelial had better integrity. So this was well tolerated without any IOP increase. However, it was only the first 3 patients, and more patients are needed for this. However, it's a promising therapy. Another promising therapy on the horizon is Olasense eye drop therapy. Now, the idea here is to target the neovascularization part of the AAK. This is a drug that's being used now off-label because the drug has been developed for high-risk corneal transplantation, so where there is vessels in the cornea prior to a high-risk transplantation, so that the drug could regress the vessels and thereby improve the outcome. It targets insulin-like growth factor receptor, which is a very key receptor which binds to insulin and the growth factors to initiate a cascade of the principally the MEK-ERK pathways, which we know are related to PAC6, but also have very important functions for proliferation, differentiation, cell survival, and metabolism. So by blocking this receptor, it's a antisense oligonucleotide drug that blocks this pathway. We evaluated this for the first time in our AAK mouse model, giving twice daily eye drops to mice at 1 month of age, and then we gave it for 3 months and then stopped the treatment after 3 months. We had a comparator vehicle group without the active oligonucleotide, and then the drug group. And we could see that there was quite a reduction in the vascularization in the drug group in the AAK mice. This was significantly reduced after 3 months of treatment. However, when we stopped treatment, the progression again increased of the keratopathy. So the drug appears to slow the progression, but that continues when the drug is ceased. So it appears to work in early stage keratopathy before there's a progression to the more aggressive grades. We saw that it doesn't affect the chamber depth. And also, interestingly, we did a histologic analysis. It increases the thickness of the cornea, especially in the peripheral cornea epithelium. And this is via a factor called LARS2, which is part of the oxidative phosphorylation pathway. So we see evidence that the oxidative phosphorylation is increased, which is a pathway that's very important for epithelial renewal from this drug. So what is next? With this first result in the animal model, we're now at the stage where first-in-human clinical trial is being conducted with Olosense.
Dr. Lagali, sorry
Yes.
to interrupt you. There is a pop-up screen coming on your screen of
Sorry.
filmmaker. Half of the
Yes,
slide is
sorry.
not visible. Yeah, please could you?
Sorry. I'm sorry.
Yeah.
Yeah, thank you.
Thank you.
Thank you for letting me know. So now with these results, we're the first human clinical trial with this drug has started, and this is in patients with early to moderate stage AAK, and it's being done by Professor Klaus Kersifin and colleagues at the University of Cologne in Germany as part of the EU Restore Vision project. Importantly, in that trial, there's a participation of the patient advocacy organization Aniridia Europe, who were involved in the trial design as well as the ethics preparation for that trial. And the trial started just last month. So patients, just like in our mouse model, will be treated for 3 months and to see if this can possibly delay or halt the progression of AAK, as well as to get information on safety and tolerability of the drug in the Aniridia patients. Another new, very promising AAK therapy on the horizon is losartan. You may know losartan, it's a approved drug, but we're now considering this is repurposing of the drug. It's an angiotensin II receptor antagonist. It's been used for many years as an oral hypertension medication. It has another effect that it inhibits TGF-beta signaling. And as we know, TGF-beta is a critical factor in the transition of keratocytes in the corneal stroma to myofibroblasts, which then are responsible for the formation of scar tissue. And this was first proposed as a repurposed drug by Professor Wilson in the United States, who formulated this as an ophthalmic formulation. And started treating patients with this, which had corneal scarring, and showed that there were no side effects. So it's used now off-label for treating corneal scarring, giving 6 eye drops per day. It's been tested in established corneal scars like alkali burns. Combination of losartan and corticosteroids has been used for burns. And it's been shown to have a good effect in already established scars, for example, after the herpes zoster infection. In terms of scarring in AAK, there was a patient in the United States that has been using this for 9 months with markedly improved vision. This is just one patient, anecdotal. However, it's quite promising. The drug has been reformulated in European countries as well for as eye drops, and patients are being treated. Aniridia patients are being treated now in Bulgaria and Germany with this, with good results. As yet, there have been no literature studies published, but this could be very promising for future clinical trials. And what's really interesting here is that it's can be effective against already established long-term scars to regress these. And finally, some other approaches for AAK that are on the horizon. Of course, we know the LSCD in Aniridia is bilateral, so searching for other sources. The group of Yoshinori Oi and Koji Nishida in Osaka is planning a new iPSC trial for patients later this year, and this should be including Aniridia patients. So these are donor cells that have been reprogrammed to induce pluripotent stem cells and then differentiated to a limbo-like stem cells, and these are transplanted then to the ocular surface in these patients. So we're waiting for the results, and these would be quite promising for Aniridia patients. Also, we heard also mentioned by Professor Sangwan, MSC or EVs. We have a collaboration, we've been collaborating with Ireland, who produce EVs from MSC sources, humans, MSCs, and these have now been tested in a traumatic mouse model of LSCD and show some good effects, promising effects in suppressing inflammation and promoting wound healing in the context of LSC. So this could be something for the future. And finally, I wanted to mention gene therapy because multiple different approaches for gene therapy and different research groups in Europe, but also around the world actually have been starting to use this and looking at aniridia. There are different gene editing tools. Some are base editors or CRISPR-based gene editing tools. And also the delivery vectors can vary quite a bit. They could be lipid nanoparticles, or they could be adeno-associated viral vectors. And it still hasn't been worked out what is the most efficient route of delivery. And as to date, it's been yet to show that there's efficient gene correction in the cornea in any in vivo model. But I think this is something that's going to be coming in the coming years. So this is quite promising as well. And with that, I'd just like to thank you very much for the invitation. And I'd like to thank my whole team in Sweden who's contributed to a lot of this work, and also our collaborators within the Restore Vision project. Thank you so much.
Thank you, Dr. Neil. What you have shown definitely looks very promising. We have some questions in the chat. Before I take those, I just have a few of my own. You mentioned duloxetine targets PAC6, right?
Yes.
And Olesense targets corneal neovascularization.
Yes, correct.
If you had to, losartan, yes, we have been using, not specifically in aniridia, but one question would be, would you want to at all, because you are giving it in drop form, would you want to at all change the drug delivery modality for it to be longer on the eye or on the surface at least?
Yes, I think that this is a limitation today. The eye drops that are currently being given. We did test, as I mentioned, in collaboration with Professor Brémond-Gignac and their group. They have been doing formulations that are increasing the residence time of the drug on the ocular surface. Yeah. So this is one approach. But ideally, we would like to have it actually as a kind of a slow release or long acting formulation if possible. We haven't come that far yet. And I could think also that perhaps delivery subconjunctivally, yes, or perhaps even intrastromally could be better. If it's combined also with something that's sort of slow release or long, I think could be something that could be useful. Yeah.
And just another one, like losartan has been used for aniridia by your group. How young do you think, what age group have you been able to start with?
So we haven't ourselves been using it, but our colleagues have been using it, and they so far I've only heard about it being used in adults. So I don't have any information about children. So right now adults, and right now it's just the same regimen as for other types of scars. So we don't have much evidence, unfortunately, yet, especially in aniridia. But this is really quite a promising. Yeah.
Just picking up the questions from the question and answer. So Dr. Sushmita is asking, why do you think the CCT is thicker in aniridia if the epithelium and basement membrane are thinner on histology?
Sorry, why do we think the CCT? Yeah, CCT. Yeah, so it's that is the actual mainly the stromal thickness. It's thicker. We have and others have looked at, for example, the endothelium. That we don't seem to see any sort of dysfunction in the endothelium. If we consider, we don't consider just the pannus. The cornea itself on its own is thicker in aniridia. And what we feel is that this is a developmental result of a developmental deficiency in aniridia, because we know that the cornea should become thinner closer to birth, and it is thicker in utero, and then it gets thinner, and somehow this process is disrupted and it's not reaching the proper normal thickness.
I may add something. It has been published that the cornea at birth, I mean, not when they are older, the cornea is really thicker. And so more than 600 microns. And so we know that. So even if you have a thinner epithelium, so you can't have a thinner cornea. So we know that, and this is quite, I mean, this is quite common to see that in anterior segment dyskinesia. So it's not only aniridia. Aniridia is special for sickness, but you can find that in other anterior segment dyskinesia. So that's
Which is
why it's
And
quite
yeah,
disruption of the normal
Yeah.
development. Yeah.
also the epithelial barrier is not functioning. So there is also stromal edema. Like we see a lot of aniridia patients with stromal edema as well. We believe the endothelium is non-functioning, but yes, there are papers which show that the endothelium is functioning properly. But then again, the tear film has fluid and the epithelial barrier is not functioning.
But you find that even in very young children,
Yes.
like 3 months old.
Yes, true.
So, and the problem of the epithelium is functioning. It's not a big problem. So it's even that it's thicker.
Yeah, there's quite a range in phenotype. I mean, we even see older adults with a completely clear cornea, and those cases, the endothelium is quite functioning quite well.
Any other questions? I will just go through the chat once more. And okay, Dr. Neelam is asking, any specific tear biomarker in these LSCD AAK patients that you have been looking for?
Yes, so we know that the tear film proteome is quite altered in AAK or in aniridia in general. For example, important biomarkers can be the inflammatory biomarkers. We know that IL-1 beta, for example, very important. And actually, what we found was the ratio of IL-1 beta to IL-1 beta receptor antagonist is markedly changed. So meaning that the inflammatory part is the IL-1 beta is higher, but also the receptor is lower, so it's kind of exacerbating it as well. So we're having very high levels of IL-1 beta. There are other, for example, IL-10, which is the anti-inflammatory cytokine, is reduced in aniridia as well. So it's kind of pointing to the same kind of chronic inflammation, these biomarkers.
Any other questions from the panelists? Then requesting Dr. Dominique, could you please share your slides?
Right, I'll try to do that.
You're very clearly audible. Yes.
Do you see my slide?
Yes.
Okay, very good. So, okay, so it will be something different because I just would like to specify the phenotype of PAX6 anomalies and congenital aniridia. And I just would like to thank all of you for this invitation on Aniridia Day. And Neil Lagali and me are representing Aniridia Europe Association. So it's a pleasure to have been invited and with your team. I'll try to go this way. So we know that it could be congenital aniridia with sporadic family, Vagro syndrome, and also Vagro or Gillespie syndrome, but we will talk about congenital aniridia, PAX6 anomalies, because there is also there will be other gene also. So we have been looking at our CIMERA database, which is 394 aniridia patient, 788 eyes from 2014 to 2023. But to date, we have 475 patients from 2014 to 2026. So in those patients, so we have presenting congenital aniridia and retrospectively reviewed and with clinical findings recorded. So we classified classified the complete aniridia, presence of an iris root of iris remnants, partial aniridia, and genetic results, of course, for PAX6 gene defects were noted absent or present. So you can see here very easy on the top because it's a complete one, and very partial on the in the lower part of these patients. So method, we explore posterior segment of the eye to better define the finding in congenital aniridia. It was the first study on the fovea using SD-OCT optical coherence tomography and OCTA also. And the second study will be on the optic disc and using ultra-wide field imaging optos incorporation. So first study, you know about the retinal layers. I will not stay longer on this, but the problem in, of course, congenital aniridia PAX6 related, it's foveal hypoplasia. So there was some difficulties to perform these OCT and OCTAs because there is some corneal opacities. There's also cataracts. You can see here, cartwheel cataracts, which is absolutely pathognomonic, and the nystagmus, and the patients need to fixate. So there was not all the patients that couldn't go through. It was to correlate the degree of foveal hypoplasia with BCVA, iris phenotype, and PAX6 mutation. And we really know that's a rare congenital panocular disorder, but there were more than 700 pathogenic variants that were reported. And it's really PAX6, which is a major genes. But in our cohort, we have around 10%, which are non-PAX6 with aniridia, and other gene responsible for this congenital aniridia. But this was interesting because we knew that in the foveal development is really different, and it's problematic. And also this is a case that explains the low visual acuity in those children. So the patients with high quality SD-OCT were recorded, and with available genotype that were retrospectively included. We, of course, used the classification of Thomas and Irene Gottlob, and of course, classified, and also with the iris hypoplasia classified too. So this first study just recorded that to better define the congenital aniridia. And so what are the results? So mean age was like 20 years old, with a range of plus or minus 16 years, with 95 patients, 58 females and 37 males, and they showed variable degrees of foveal hypoplasia, as you can see here, and the grade 1 until grade 2, and only in 11 eyes there were normal fovea, but of course you can see here then most of them has a foveal hypoplasia of high grade. And the BCVA was correlated with the degree of foveal hypoplasia. And so you can see here that, of course, you have less visual acuity, a lower visual acuity with grade 4, and of course, much better with grade 1. So how was the distribution? And you can see here, 73 eyes show the grade 4 foveal hypoplasia here on those, and you see the repartition of the other. The degrees of foveal hypoplasia was most frequently correlated with severity of iris defect. However, among eyes with mild iris phenotype, 70% showed severe foveal hypoplasia. So PAX6 variants were found in 88 of the 95 patients on this cohort in 92.6%, and PAX6 positive patients presented a higher degree of foveal hypoplasia than patients negative for PAX6 anomalies. So PAX6 was deletion, nonsense, frameshift, splicing, and CTA variants, and mostly associated with grade 3 or 4 foveal hypoplasia. So patients with missense mutation presented with variable degree of foveal hypoplasia, probably because it's less intense, and deletions restricted to the three flanking regulatory regions of PAX6 were associated with a lower grade of foveal hypoplasia. So you can see here the BCVA was higher and the foveal outer layer was thicker in patients with deletions regulatory region of PAX6. Here you can see on grade 4. And so on the missense mutation and also regulatory regions is lower. So all types of PAX6 variant, even those associated with mild iris defect, may be at risk for severe foveal hypoplasia with poor visual prognosis, except for deletions restricted to the 3 regulatory PAX6 regions. So foveal hypoplasia is most reliable sign to confirm congenital aniridia diagnosis in PAX6 mutation, just compared to only iris anomalies. So just look at these patients. It is a mother. She had been identified as only coloboma, and of course it's not. This is a daughter, and you can see here the foveal hypoplasia, which is complete, even if there is very, small anomalies of the iris. So the second one was to see OCTA, and so to explore the posterior pole with OCTA, and of course it was also very difficult among the 30 patients. So to compare foveal vessel density and sex match also, and 10 of 18 patients related aniridia patient and 10 control. So you can see here the control and just look at the PAX6 in both cases, and it's absolutely demonstrative that on the foveal area, mean vascular density was higher in aniridia patients, which is really demonstrated than in controls at the level of ICP or DCP. And on the parafoveal area, mean vascular densities was lower in aniridia patients than the healthy subjects at the level of plexiform and respectively. So there is a real positive correlation found with the grading of foveal hypoplasia and of the foveal vascularization. So in conclusion, vasculature is altered in PAX6 related aniridia, higher in foveal and lower in parafoveal areas, especially when foveal hypoplasia is severe, which is consistent really with the concept that absence of retinal blood vessels is essential for the foveal pit development. That was published. The second one, and this will be the last one, is to explore the posterior segment, but only on the ultra-wide field imaging to see the optic disc. So it was to characterize optic disc hypoplasia in congenital aniridia, and we also investigated the relation between optic disc and hypoplasia and foveal hypoplasia. The disc diameter and the disc to fovea distance were measured, and the ratio disc diameter and disc to fovea ratio was used to assess the relative size of the optic disc. The analyses were carried with respect to paired age and sex-matched LC control. So just look at the ultra-wide field imaging we have. And so you can see here the control, and on the right side, you have PAX6-related aniridia on the wide field. And you can see also the lines to fovea, or you try to get a fovea with foveal hypoplasia, which is difficult, of course. So it was mean manual and mean semi-automated to control that, and in aniridia patients. And so you can see the differences between PAX6 and control on all that we measured. And the negative correlation was found significant between the grade of foveal hypoplasia and the mean semi-automated DD-DF ratio. So you can see here, as you can see on the slides and on the OCT. So also significant negative correlation was found between the peripapillary temporal RNFL thickness and the grade of foveal hypoplasia too. So in conclusion, the DD-DF ratio is significantly reduced in PAX6-related aniridia patients, and it correlates with the severity of foveal hypoplasia. And this ratio is a valuable tool for optic disc hypoplasia assessment in congenital aniridia, specifically when provided semi-automatically by UWFI. So we had also a therapeutic education program for patients, and really this study confirmed the correlation between the grading of foveal hypoplasia in a larger cohort of patients. Additional cause of reducing VA is nystagmus, anterior segment disorders, amblyopia, refractive errors. Grading of foveal hypoplasia is correlated with low vision and can help deciding whether further treatment of investigation are necessary to improve the patient. So half of the patient with partial iris at grade 4 hypoplasia. So congenital aniridia, most reliable sign is hypoplasia of the fovea and not the iris anomalies. And vessel density is higher in foveal hypoplasia. And regarding the size, there is also reduced size of the optic disc. So for these studies, we have Professor Alejandro Darish, Professor Robert, Professor Valex, and me. And you can see here our hospital with the Eiffel Tower here. And also, if you are interested, you can go on UMIS, which is a new European Myopia Society. Very easy, and you can go on the website. It's free to register. You will have web conferences too. This is a UMIS European Society experts, and I hope we can probably go further together to have a partnership. And this is my team, and they support me every day. I'm very happy with them. So thank you very much for your attention.
Thank you, Professor Brémond-Gignac. And that was a wonderful lecture. And these are the aspects of aniridia which are really not well studied. And we also used to wonder when we are seeing these patients with partial aniridia, why vision is so less in them, or does it correlate with the amount of foveal hypoplasia? And thanks to you for solving those queries, because several times it is not, the aniridia, the absence of iris is the most striking feature that is visible, and we tend to correlate the vision with that. But it's not actually that, it's the other comorbidities which actually determine the vision. So thank you so much. One question from my side is that semi-automated foveal hypoplasia, that disc diameter or the disc distance, I didn't understand how was it calculated? Like in the absence of that foveal hypoplasia, how can you really calculate it?
So we can calculate the ratio on the optic disc, and also the distance between and the orientation. And that was semi-automated because we could go on the Optos and calculate the distance. That was this one.
Mm.
And so that's why we just demonstrated that there were an optic disc hypoplasia, which is not somehow very obvious, because sometimes it's difficult to get a good imaging of the posterior pole.
Okay, thank you. There's one question in the question answer area that how were the reliable OCT measurements taken in aniridia patients with nystagmus? Dr. Nina is asking.
Yes, for the nystagmus, of course, it's directly related to foveal hypoplasia when the children are young. Of course, if you have all the pathology like aniridia-related keratopathy, it's different because you can have a difference in this way. But when you go to children, because I'm pediatric ophthalmologist, so when you have children, you see very easily when they have nystagmus, you know that there is foveal hypoplasia without any other, of course, examination, but you do it. And sometimes you have grade 1 or grade 2 without any nystagmus. And so there is responsibility for the low vision.
Mm-hmm. Did you happen to study the PAC6 genotype phenotype with the other complications of aniridia also? Especially, we see a lot of patients with that superior subluxation of lens. Yeah, we see that in quite a few patients. I mean, almost like 20% of our patients in our data is showing that kind of superior subluxation, sometimes very mild, and then it goes, to increase. Is there an association of, any particular type of
That's
PAC6
true.
variation?
Yes, I saw your lenses. It was not the point today, but and you have exactly the same as my patient. So of course there is a real there is really an involvement of PAC6 in the lens development, and we published a paper with Maleda Duncan and demonstrated that the lens in PAC6 mutation is even without any other like coloboma of the lens, but without that, the lens in PAC6 anomalies is smaller. We demonstrated that comparing. So it was interesting because we had to understand how we could demonstrate that the lens in congenital aniridia is smaller, because you can see it, you can measure it, but the problem is what to compare. And so I have also a cohort of albinism. And when you have albinism, you know that there is you can see the lens by looking on transillumination. And so in albinism, there is no involvement of the gene in the lens, and there were significant differences between lens size in congenital aniridia and lens size in albinism. Yeah, so we have difference for sure, and PAC6 is a major actor of lens development.
Yeah, many a times because of the rim is seen, it is misdiagnosed as microspherophakia in aniridia patients, and even documented like that. But yes, now that you're saying, yes, most of the lenses are smaller and slightly upward shifted in most of the photographs, and many of them do have that, very typical subluxation, which is always superior, which I've seen.
Yeah,
Due to some,
that's true. It's subluxation or something is coloboma too.
yeah,
I think a part of the lens is missing.
missing.
And also we must be aware of that, because when we do a cataract surgery, there will be sometimes posterior lenticonus, so an opening to the vitreous. So that's interesting too, because if you don't perform UBM, you don't know before, but you must be aware of it and be careful. Yeah, I'm sure you had operated a lot of those patients.
Yeah, thank you. Dr. Nina has some more questions. I think she's asking again about the distance from disc to fovea, which Dr. Brémond has already answered that question. She's also asking that was it measured under GA with handheld OCT in pediatric patients? Your OCT measurements. OCT, was it done under general anesthesia with a handheld OCT?
For the OCTA, it was not, of course, non-general anesthesia, and we did that with standard OCT. And we do perform OCT under general anesthesia. The problem is the OCT is not such with a good definition. So for the study, it was not under general anesthesia. We do that when we want to phenotype the children, but not for the study.
Okay. I have one more question. Again, not very much related to your talk, but as a pediatric ophthalmologist, how do you manage cataracts in aniridia?
Right. So what I see is when you perform cataract surgery in congenital aniridia, clearly it affects more the cornea. So
Yeah.
I try to do that slower. I try to defer the cataract surgery because I think it's not good to go very early. And many ophthalmologists don't understand that there is hypoplasia of a fovea, and this is doing a low vision, and it's not the cataract. So it's very complex. About the cataract, you have both kind of cataracts. You have anterior, subcapsular anterior, and those usually you don't have to operate even if they are congenital because it's anterior and made in most of them it's not too large, it's not too wide. You just operate when it's really very extensive. And then the second kind of cataract is cartwheel cataract, which develop with age. It's not initially done. And so you need to evaluate if there is really a loss of vision to go and operate. And be careful, of course, of the keratopathy, because when the keratopathy is too opaque, so it's difficult to operate. So it's a balance between the clear cornea, the cataract, and the vision, and to understand when you go to surgery or not.
Yeah. Thank you. Thank you. That's it from my side.
There
Questions?
are
Any
some
other
more
thing? Yeah.
questions. Sorry.
Are there?
There are
Yeah.
some questions in the chat, in the other chat, not specifically in Q&A. Do you want to take them up?
Yeah, sure. Can you take them up? I am not able to see them.
So there is a question. I'm sorry, the name is not there, but they ask, there are reported cases of isolated foveal hypoplasia without associated aniridia. And in such cases, do you think PAX6 gene mutations still play a role in the pathogenesis?
Yes, we can have no iris anomalies and foveal hypoplasia with PAX6 mutation, and sometimes it has been not well identified because it's unusual. But for sure, PAX6 is playing a role, and usually those patients are specific mutation and lower, I mean, missense or lower mutation, right?
Also, just following it up, there is, could WT1 interact with PAX6 and pathways involved in angiogenesis or neovascularization? And has such an association been documented or demonstrated in literature?
Okay. I don't understand exactly what they are looking for. Correlation with foveal hypoplasia and OCTA, and it's we have a correlation between the grade of the foveal hypoplasia, but not with the vascularization. But what I can say is when the vascularization of the fovea is higher, so you have a higher grade. So it's indirect. We did not demonstrate that, but it's indirect, and probably that's true.
I can say in terms of if that question is directed towards the anterior segment or cornea, I can say that I don't think there's a direct interaction of WT1 with PAX, but what we see is with the Wilms tumor deletion, you have the deletion as well as it's close on the chromosome, right? So it's the PAX6 gene is deleted as well as the Wilms tumor gene. And what we see there is in that case, at least in the front of the eye, the keratopathy is more aggressive. So it's a much more aggressive phenotype of the neovascularization and at a much earlier age as well.
You're right. Yeah, I agree. Thank you, Neil.
So I think we have discussed most of the questions. Yes.
Can I ask a question to both
Yes,
of
sir.
Is anyone or anywhere in the world people doing intrauterine gene editing for PAC6? Is that possible?
So what is being done, and I know it's been done in Spain, and perhaps it's going to spread to other countries, is it's not gene editing, it's in vitro fertilization with testing and the selection of embryos which do not have the PAC6 mutation. So that's being done.
Pre-implantation.
My
Yeah,
knowledge,
pre-implant.
gene
Yes,
editing, yeah.
pre-implantation, yes, but not
Yeah.
edited.
Implantation, exactly.
Right. That's a very good thing to do further. Virender, thank you for the asking.
Because that looks like the major issue I mean, the problem has happened, we are trying to fix after effects of the main problem.
Okay.
Yeah, that's on the wish list for many, many
Right,
diseases.
exactly, that's true. Very good. Okay.
Anything else, Elsa and Abba, or we are done?
There's one last question maybe we can take from Dr. Adedayo. How do you manage photophobia in them? Do you use contact lenses in all? I find many have a flatter cornea that makes contact lens difficult. Maybe
I
both of them
answer,
can
right.
take it one by one.
Okay, I think we need to explain that contact lenses, usual contact lenses, are absolutely contraindicated because of the limbal stem cell deficiency. So the only point is scleral lens that we adapt. And for photophobia, of course, there is a lot of filters. You can go on the spectacles. And I do not prescribe and never prescribe contact lenses, even with some painted contact lenses, only scleral lenses.
Professor Lagali, you want to add something to it?
I think that's exactly the same
Yeah.
thing. Actually, the scleral lenses can be useful, right, with the fluid interface. They actually can provide pain relief to a lot of patients. So this is common, but yeah, as Dominique.
Could that be used as for drug delivery as well in Aniridia? Scleral contact lenses with some drug in that field.
That have been used by
Yes. Yeah.
in Boston.
I'm not aware of any clinical studies on that. I think that would be a really good kind of something to publish, study.
Yeah.
Good.
Okay, thank you. I think we just overshot the time a little bit, but we're
We are
anticipating
very much on time.
it. Yes. So thank you so much to all our panelists, especially Professor Brémond-Gignac and Professor Lagali and Dr. Sangwan.